Okay. We ready to go? Yeah, okay. Hello, everybody in the room and online. My name is Gwen Driscoll. I am the Director of Communications here at the UCLA Center for Health Policy Research. Welcome back to a new school year and a new health policy year that we hope, although we are not holding our breath, will be slightly less rambunctious than 2017. But before we get on to our main speakers, let's just talk about next month's health policy seminar at the center. A common myth about undocumented immigrants in the United States is that they place an undue burden on the nation's healthcare system and especially the safety net. In 2016, the center was host to Paul Dornion, a center faculty associate and the research director at the Paris-based Institut de Recherche et Documentation en Économie de la Santé. Paul was also a 2016-2017 French Harkness Fellow in Healthcare Policy and Practice based here at the center. Using data from our California Health Interview Survey, as well as county stakeholder interviews, Dornion assessed how well immigrants are served by California's safety net and what the health outcomes are for immigrants who are able to access services. On Wednesday, February 21st, Paul returned from Paris to, among other things, talk to us about the results of this research, which could not come at a more timely moment in light of current political debates. Again, that's February 21st at noon. Okay, as always, we are recording today's seminar and it is accessible in our newsroom at healthpolicy.ucla.edu/newsroom. If you're watching online, would like copies of today's slides, please email me. My email address is in the middle here. And please also note we will have a brief question and answer period at the end of today's seminar that I will moderate. And if you're interested in all our upcoming research and data, please subscribe to our free monthly e-newsletter, Health Policy News. And that's the link you see at the bottom. Okie dokie. Today we're going to shed light on a topic in a population that has been historically underserved: older adults with mental health needs. In 2004, the state passed the Mental Health Services Act, which aimed to transform the delivery of public mental health from predominantly providing crisis care to a consumer wellness, recovery, and resilience model. Included in this is an older adult system of care that is supposed to provide mental health services to California seniors. Today, the authors of the first evaluation since the passage of this act are here to tell us whether this program has improved outcomes for older adults with mental health needs and what California could be doing better. Leading this evaluation is Center Faculty Associate Janet Frank, an adjunct associate professor in the Department of Community Health Sciences at the UCLA Fielding School of Public Health, and an expert in gerontology and healthy aging. Among other things, Janet directed the UCLA-based California Geriatric Education Center and Interdisciplinary Statewide Training Center. Frank continues to serve as principal investigator of the Model Career Technical Education Certificate Program for community colleges, Skills for Healthy Aging Resources and Programs, which prepares entry-level personnel to work in community-based aging service organizations that offer evidence-based health promotion and disease management programs. She is also president of the Association of Gerontology in Higher Education. Center researcher Kathryn Kietzman is an expert on social welfare and in particular the health and social care needs of the most physically, socially, and financially vulnerable of older adults who rely on public supports to continue to live independently at home. Over the past several years, she has led a series of studies about managed care, clinical preventive services, as well as long-term care. Their evaluation, which is available today on our website, www.healthpolicy.ucla.edu, includes 5 separate studies or documents about the state's older adult system of care, plus a whole bunch of supporting materials. Please take a look as they contain lots of recommendations on data collection, on workforce training, on promising programs, and much more. And now please welcome our speakers, Janet Frank and Kathryn Kietzman.
Thank you. Well, it's great to be here today with all of you. I'm Janet Frank, and I'm going to be starting off, and we're going to do a little bit of a tag team with my co-principal investigator, Kathryn Kietzman. So today we're here to talk about the California Mental Health Older Adult System of Care project that was funded by the Mental Health Services Oversight and Accountability Commission at the state. We began this work in 2015. And I'm going to first tell you a little bit about the background for the study. Then we'll go through our research question, our study methods. We'll spend quite a bit of time talking about our study findings, and we'll conclude by looking at policy recommendations and other ideas for improving the older adult system of care and mental health services for older adults. So to begin with, the Mental Health Services Act was passed in 2014, and it promotes a recovery and resilience model. The MHSA, as we've come to call it, is also known as the millionaire's tax because it is an additional tax that is levied on California residents who make more than $1 million. Probably all of us have paid into that, right? The goal of the Mental Health Service Act was to transform public mental health services into recovery and a resilience model for the seriously mentally ill in California. It has a number of components. A primary and very large section of it goes to community supports and services. These are the kinds of things you would think of as more counseling services, but within that program is a very important model program called the Full Service Partnership. The Full Service Partnership allows counties to put together packages of services of whatever it takes to help people recover. So that can include employment counseling, it can include housing, and a variety of different kinds of services. It also introduced a prevention and early intervention program, which we'll talk more about. It also provided funding for workforce education and training, and it offered also an opportunity for counties to write special projects called innovation projects to test out new models and try new things that they thought would bring better services. And all of these are for services across the lifespan, from young children up to older adults. Another component early on in the Mental Health Service Act was for capital funds to be able to build structures as people needed those. So that's the Mental Health Service Act. Let's talk a minute about the older adult system of care. The older adult system of care, or OASOC, actually predated the Mental Health Services Act. And it became popular in the early 2000s, and our project adopted a framework that was put forth by the California Mental Health Directors Association. First evolved in 2001, and then it was revised in 2005. The older adult system of care has a set of values. And these values really emphasize recovery and resilience, looking at strength-based care, quality of life, and client empowerment. Its service systems also have value statements around diversity and also consumer-oriented care planned with consumers. And they provide or suggest the provision of a continuum of services, including transitional pathways and development of partnerships with other agencies. So the goals and the approaches of both the older adult system of care and the Mental Health Service Act are very consistent and complementary. So this brings us to our primary research question. Our study asked the question, what progress has been made since the passage of the MHSA towards implementing an integrated and comprehensive system of care for older adults with serious mental health needs? So that was our primary research question. Our study was a fairly small study. We focused on 6 counties, and we very carefully and deliberately selected these counties based on a set of minimum criteria that included things like the region, the county size, the population density, the resource level, and the proportion of older adults, and the status of, within these counties, an older adult system of care. So these are our 6 participating counties: Siskiyou, which is way at the tip top of California, Alameda, Monterey, Tulare in the San Joaquin Valley, Los Angeles, which is actually its own mental health region, and San Diego. Specifically, only one of these 6 counties at the time we started our study had a formally designated older adult system of care as part of its administration. 2 counties had a joint adult system of care combined with an older adult system of care, while the remaining counties served older adults within their adult system of care, and 1 county offered services for older adults only as part of their adult programming. They had no specific programs called out for older adults. The methods we used were multiple and extensive. We first began reviewing over 100 reports and articles that have been generated about older adult mental health, and specifically about the Mental Health Service Act. We reviewed over 100 of these, and we analyzed 35 of these. So that became our secondary data process. We also collected primary data by interviewing 72 key stakeholders. 13 of these were at the state level, and 59 across the 6 counties. Then we also ran 6 focus groups. They included a total of 44 people, and they were only primarily consumers, but also family members. So this was to have us be able to gain a very important consumer voice that augmented the key stakeholder interviews. And then finally, in addition to our contracted activities, we did a survey of all counties currently for the status of their older adult system of care. And we'll be going through all of these things in detail as we proceed. For the secondary review, we learned that so far, as of 2017, the Mental Health Service Act has generated $13 billion for the state of California, and that actually comprises about 25% of all mental health service funding that the counties receive. We also found unanimously that reporting was seen to be inadequate for MHSA outcomes, and this needed to be strengthened. We also saw that seniors and veterans were the least common stakeholder groups to take part in MHSA planning. Now, why is this important? It is important because all decisions about MHSA funding happen at the local county level. So part of the value statement of the Mental Health Service Act was to involve this very specific mandatory planning process to be able to have these grassroots voices help determine what kinds of services and needs were, how to spend the money. And so the fact that we are not having older adults adequately represented in the planning process equates directly to issues around resource allocation. On the other hand, we found that data showed a steady improvement in the numbers of older adults receiving services since the Mental Health Service Act. This makes a lot of sense because with the influx of the additional funds, counties were able to expand their service networks and provide more services, and also had the funding for these specific services around prevention, early intervention, integrated care through innovation programs, and the increase of service latitudes of the full service partnership. All of that said, all the documents that we looked at said that there continued to be great unmet need across all Mental Health Service Act services. So this is the data from our survey. On secondary review, we found that about a quarter of counties in California, not just our 6, but a quarter across the state, in 2004 had an older adult system of care administrative unit. But as of October 2017, when we finished our study, we found that 40% reported having this older adult system of care within their Department of Behavioral and Mental Health Services. And so the way that we did the survey was through a Survey Monkey to the Mental Health Service Act coordinators in each county. We got a number of responses from the survey, and then we followed up by phone and a couple through email to be able to reach a 100% response rate. And so this data is, I think, very promising in that we've seen an increase in these structural administrative units across the state. The reason that that's really important is because based on our interviews and our secondary data, we found that counties that have an older adult system of care administrative unit have many more programs for older adults specifically, better trained providers, and they're able to offer more services to more people. Yet, during our study, which is kind of amazing, 2 of our 6 counties actually reorganized their administrative units, and they collapsed their older adult system of care unit into their adult system of care, or they combined them to be jointly under one administrative unit, eliminating a distinct unit for older adult services. So now I would like to invite Kathryn to come up, and she's going to be able to share some of our findings.
Good afternoon. Great to be here and to see everybody in the room and those online. Welcome. I'm going to be talking to you a little bit about the findings from our primary data collection phases. We had 2 collection phases, one with key stakeholder interviews and one with focus groups. So I'm going to talk a little bit about those. First, I want to tell you a little bit more about who those stakeholders were in our stakeholder interviews. So Janet had mentioned that we completed 72 key stakeholder interviews. 59 of those were done with county level stakeholders. That included consumers and family members, mental health administrators, clinicians and direct care providers, both from the mental health departments and from aging services providing agencies. Also, advocates and a health and human services administrator were included in that group of key stakeholders from the county level. And then at the state level, we talked to a broad range of administrators in public health, in healthcare services, at the Office of Statewide Health Planning and Development, administrators at Aging Services Department, and then also administrators at state level associations and commissions and councils. We also talked to a couple of state level advocates. So the total of 13 key stakeholder interviews were done at the state level. So based on our review and analysis of the 72 key stakeholder interviews, we identified 8 major themes and developed narratives representing all of the nuance and dimensions within these themes in our findings reports. So this I like to think of as our Wheel of Fortune in a way, but these are sort of the main themes. We have status of an older adult system of care, which Janet already mentioned, values, system level planning, pathways to care, service gaps, housing needs, workforce training and supply, and the promise of integrated care. So I can't go into great depth with each of these in today's short seminar, but I'm going to talk to you a little bit about some of the highlights. So the key informants really substantiated what we also found through the secondary data review, that there is great variation in the development or presence of a formal and designated older adult system of care. Again, it ranges from counties that had a formal system to those that had older adults served through their adult system in tandem, to systems where there's really little or only emerging recognition of older adult specific needs. And this, again, may reflect the fact that there really is no state mandate or dedicated funding specifically to implement an older adult system of care. We did find that all counties do have programs either specific for older adults, however, or inclusive older adults, but not countywide systems per se. In all counties, we did find examples, and in many cases, some very promising examples of services that are responsive to the needs of older adults and reflect the individual values that are promoted by the Older Adult System of Care framework and by the Mental Health Services Act. That said, many counties, stakeholders reported really limited penetration with older adults and the sense that they were really reaching only a small percentage of those in need of mental health services. We learned that outreach efforts really do vary across counties, and few of the counties that we included in our study engage in older adult specific outreach strategies. In general, the feedback was that more really needs to be done to reach out to older adults who are not making their way to services. And most of the older adults that people were serving had been living with serious mental illness, often for many years, and have actually aged with the system, within the system. But less is known about older adults with late onset mental illness and how or if they're actually making their way to the services that they need. We also learned about barriers to care from our stakeholders. And we heard about some very basic barriers, unmet basic needs like food and housing. We heard about geographic disparities, especially in rural versus urban areas, or even in a larger, more urban county, rural pockets within those larger urban counties. We heard about transportation and housing deficits, an insufficient and untrained workforce, bureaucratic constraints, and also some problems with insurance coverage, and sometimes there were problems with costs of care. We also learned about gaps in services, and these included addressing the needs of older adults who had both serious mental illness and then, as they aged, had actually developed a cognitive impairment. And there were problems also with access to long-term care case management, which is a service much more useful or much more in need for older adults who have multiple chronic conditions. Also, we heard reports of consumers having difficulty getting one-on-one therapy. Many older adults wanted that, but they weren't able to access those services. And then we also heard about sometimes a lack of culturally appropriate services or services available in the languages of consumers. We did also hear about facilitators and things that were working in the counties. So the key informants provided examples of factors that improved older adults' access to care. And these included things like increased public awareness about mental health in general, increased consumer knowledge about systems and services available. The provision of home-based services was mentioned over and again as a very important way for older adults to be able to access care, where care is actually coming to them in their homes. So having smoother referral pathways for older adults who may need multiple different types of services, and making sure that those connections actually happen and that there's follow through. And then improved transportation systems. That was mentioned in many counties as an issue, both in rural and in urban counties. So across the board, we did hear many times about the value and the promise of integrated care. And this is, in many examples, it was the co-location of mental health services within primary care practices, but also the reverse, primary care practitioners housed within mental health clinics. And this was really described as an important innovation that was helping to improve the access of older adults to care, again, especially for those who have multiple chronic conditions. So this parlaying of physical health care and mental health care under one roof was seen as very valuable in helping older adults get the services that they need. So I'm going to shift next to sharing with you some of the findings from our focus groups. As Janet mentioned, after we had completed our key informant interviews, we really felt that we were lacking more, we had consumers and family members in that key stakeholder group, but it was a relatively small number, and we wanted to be able to dig deeper into what were the issues that consumers were saying were important and of concern to them. And then also, importantly, how are family members working with their older family members to help them access care? So this was the last of the 3 primary methods we used in this study. We conducted 6 focus groups in total between March and April of last year, and we had focus groups of 3 distinct types. We had Spanish-speaking older adult consumers, two focus groups of that population. We had 2 focus groups with older adults with serious mental illness who had been homeless and were receiving homeless services. And then we had 2 groups with the family members of older adult consumers. So the total sample was 33 consumers, 11 family members. The average age of the consumer participants was 66. Participants ranged in age, however, from 54 to up to 85. 61% of the consumers in our focus group were women. Approximately half identified as Hispanic or Latino, while 42% were African American. While English was the preferred language of roughly half of our participants, the other half were Spanish speaking. Again, we had monolingual Spanish speaking focus groups. So 18% were identified as monolingual Spanish speaking and 30% identified as bilingual English Spanish speaking. Important to note, I think, the extent of homelessness. Now, of course, we did have 2 groups that focused on folks who had a history of homelessness. 20 of our 33 consumers had experienced homelessness. And then often this was multiple times and over a period of many years. But we were also surprised to hear family members reporting. 7 of the family members in the focus groups reported that their loved one had experienced homelessness as well. And given recent reports of the increase of homelessness in general and a large proportion that represent older adults, the latest report from LA is that 55 years and older, it represents 25% of the homeless population in LA County. That's about 12,000 older adults who are without housing right now. Actually, this week was the housing count, so we'll get an update, and I imagine in a couple of months. So this is our focus group sample, and I'm going to walk you through a little bit about our findings. But before I do that, I just want to make, I think it's really important to note the people who participated in our focus groups, the way that we sampled and recruited them, they were all people who were connected to services. And so their viewpoint does not begin to address those who were not included in our study. We don't have knowledge about people who don't ever make their way to public mental health services and what's going on with them. But these are folks that are actually engaged in services, they're actually in recovery, and a very striking, impressive group of people. They're all survivors. Their lives demonstrate enormous fortitude, resilience. Overall, the participants were extremely articulate. They were very candid, shared all kinds of personal information with us, and they really had a wisdom that was born of their life experience. So I think it reminded us of the importance of really keeping the whole life stories and the broader social context in mind when you think about consumers of any kind of service. But in this case, older adults with mental health concerns, it's their whole lifetime that's shaped their experience and brought them to where they are in the current moment. And it's often in profound ways. Participants shared with us histories of individual and collective trauma, individual trauma in the form of coming from dysfunctional families, violence, addiction, incarceration, and then also collective trauma that was experienced more at the community level in a more socio-political context. Many of the consumers we spoke to were in underserved communities, and they had lived as minority group members that had experienced some generations of exploitation and neglect by the system. So this really emerged as an important part of the dimension that was shared with us in our focus group discussions. So through our focus group discussions, we identified 3 primary themes about what really matters most to older adult consumers of mental health services and their family members. And these are 3 sort of really overarching principles, and maybe not surprising. Maybe they matter to all of us here in this room in some way, shape, or form. So it's community, it's about family, and for many it was also about religion, and that was defined really broadly. I mean, it was organized religion for some, for others it was more of a sense of a connection to a higher being or spiritual connection. So they shared with us that religion in particular, or spirituality, was often a pathway to recovery. And it provided an important source of social connection. Family members were important if they were in the person's life. In some cases, in many cases, with people with serious mental illness, people have broken those bonds in one way or another with family members, but then they identify a new family that might be the peers that are around them. But in any event, having a sense of family and having some connection with others in a way that they defined as family was extremely important to recovery. And then being engaged with the community was also mentioned over and again as important. And often we heard about this in the form of participating in support groups. And this was a community of sorts. And then peer support came across over and again, also through our key informant interviews, but it was a resounding theme of something that many of the consumers and family members felt was very valuable, was to have peers who'd gone through similar experiences available to lead support groups and peer counseling programs. So we also heard from focus group participants about the things that sort of impede recovery. Again, we heard about experiencing distrust of the system overall and people in positions of authority or power, especially in communities marginalized over many generations. We also heard from some about specific cultural beliefs that further stigmatize mental illness. We heard about the lack of experienced and appropriate providers. Several consumers talked about wanting to have a provider that looked like them. And this was, in some cases, it was an appropriate match by race or ethnicity and language. Some family members, interestingly, also talked about how they felt it was important for their provider of their loved one that the provider would be an older person, perhaps, or at least be more sensitive to the generation that that person came from, because that would also influence their experience. And so that, there was some discussion about, can a younger provider right out of school kind of really understand what my mom's gone through, and can my mom relate with her? And there were interesting back and forth about that, because some other people in the group were like, no, of course they can. You have to give those younger folks a chance. So there was a debate about it, but I thought it was interesting to hear that there were some considerations of the age of provider that were also important. We also heard from focus group participants, and this mirrors some of the key informant findings as well, that they experienced geographic disparities in the availability of services. In some communities, they knew that a service that they wanted was available, but it was way across town. And there were also issues with bureaucratic barriers. In some cases, lots of paperwork, long waits, dense application processes, and delays in actually getting services that they needed. So in addition to learning about what impeded recovery, we also learned about what supported recovery for these consumers and family members. It was very important to people to be able to get information from a source they trusted. Again, maybe somewhat going back to that issue about having a general distrust of government providers, etc. So this came up as an important theme in the focus groups. Again, the support group with peers was seen as really, really invaluable asset and helpful in recovery. And also, I mentioned the key informants talked about the value of integrated systems of care and co-locating services. This came up as a real wish list in this sort, and when it existed, people really spoke very highly about it. A one-stop shopping, being able to go to one place to get your physical health care needs met, your mental health care needs met, and even if you have substance use disorders, having all of those services available under one roof was seen as very valuable. Again, for many, incorporating, having providers that recognize the importance of family and spirituality and religion, and having that incorporated into the recovery process was very important. Also, consumers mentioned having services for their family members. I think recognizing that family members sustain sometimes a lot of challenges with helping them and getting them to services, and might need some help themselves at times. And then finally, and maybe no surprise, consumers talked about wanting to have providers who had compassion, that it was beyond some sort of textbook knowledge and approach, that they really could tell the difference between a provider who had heart and was really caring, and a provider who was kind of walking through the steps of what they thought they should do. So I'll turn it back to Janet to talk a little bit more about our takeaways from all of this work. Thank you.
So across all of these different methods and findings, some of our takeaway messages are that the Mental Health Service Act programs have definitely been beneficial to older adults. And I think the highlights are the prevention and early intervention programs. These are often community-based. Very rarely, but we hope more frequently, they are placed within aging services and other kinds of community agencies that older adults frequent. They valued, as Kathryn said, peer-led programs, the full-service partnership programs, the whatever it takes programs were very beneficial, and I'll give you a little more information about that in a second. The fact that the MHSA brought in additional resources for county services was seen as very valuable, especially because this increased service networks and brought these prevention programs and also the innovation projects, especially those, as Kathryn mentioned, that provided integrative care services were seen as very beneficial. So this is great news, really great news. The problem is that not very many older people comparatively are receiving these services through the MHSA. So although older adults greatly benefit from the programs when they do get them, they often are not receiving them. One study we looked at in our secondary analysis, and this was a study of 45 counties, showed that about, at the time, 15 of those counties, or about a third, were offering prevention and early intervention programs to serve older adults, and that those over age 60 accounted for, okay, wait for it, 1.5% of those receiving prevention services. So this is a very stark statistic that drives the point home that older adults, are not plentifully receiving these types of services. In that same study, about 40 counties were providing early intervention services, and about 80% of those were serving older adults, but clients age 60 and over were about 13% of those receiving any type of early intervention studies. So again, great when they can get it, and they need to be able to access these more frequently. When older adults are linked to services, for example, the full service partnerships, we saw data that showed that costs of care were reduced, hospitalizations were reduced, emergency psychiatric care was reduced, and these are very important documented outcomes for older adults. And also homelessness was reduced, arrests and incarcerations were reduced. So all of these things are very, very beneficial, but we just need to provide this more frequently to older adults. We identified a number of key policy recommendations based on the issues that we identified. For example, the uneven implementation of services across counties. We believe that that would benefit greatly by designating an administrative structure, or at least a person whose responsibility it is to be in charge of older adult services. The inadequate reporting of mental health service outcomes. We didn't spend a lot of time talking about that today. One of our policy briefs does discuss that in depth. But basically, other than the full service partnership data, counties are not required to report data based on age, race, ethnicity, or other important characteristics that we feel need to be reported. So again, our recommendation would be about creating more mandatory and standardized both needs assessment and also data reporting. We saw significant and persistent deficits in the geriatric workforce. And so for this, even though the workforce education and training funds were available, it is unknown how many of those funds or how much of those funds was provided for training about older adults. The state does not keep that data. And so we know in many counties that have an older adult system of care presence, that they have a very robust training program. But in other counties, they may have had over the past 10 years, 1 day of training about older adult complex needs, or perhaps suicide prevention for older adults. So we definitely believe that we need to have more geriatric focused training for mental health professionals, and also cross-training for mental health and primary care about mental health needs of older adults. The barriers to public mental health, including unmet basic needs and food, transportation, shortage of transitional programs. We believe that if older adults were more involved with the planning process, and there was actually outreach to older adults who are not making their way into systems and not making their way into the planning discussions, that we might be able to create more services along those lines. We believe that there are just huge issues of geographic disparity, as Kathryn mentioned. One of our findings was there's kind of a zip code lottery. In other words, what you get depends on where you live. And people knew there were things in other parts of their county or other parts of their city, but not available to them. And you know, so basically what we're doing is we're creating unequal access to care across the state by allowing those kinds of things to happen. We need to invest in older adult prevention programs. They work, and they've been shown to reduce these higher costs. And all of these different policy recommendations and more are described in our policy briefs. And we hope that you'll have a chance to take a look at those. So what will it take? How can we move a policy recommendation into an actual policy action? And we believe what it will take is leadership. Right now, there is not any person at the state, and there is often no one at the county level who speaks on behalf of mental health and older adult issues. At the time that the Mental Health Service Act was passed, there was a liaison between the California Department of Aging and the Mental Health Department. But when the Mental Health Department collapsed into a unit within the California Department of Healthcare Services, those liaisons went away. So now there is not one person who's the watchdog for older adult mental health issues at the state level. So we believe that that position should be reinstated. In addition, we believe that at every county level that there should be an older adult system of care designee, if not an administrative unit, and there should be one person whose job it is to take care of the needs and address the needs of older adults. As described in our policy brief, that we need to set a minimum standards for program delivery and care across all age groups at the state level, and we need to collect the data so we know what's going on. We need champions at every level, including champions across programs. We'd like to see that formal linkages would be established between the county mental health, and oftentimes this is now called behavioral health, with the area agencies on aging, behavioral health, substance abuse programs, housing, protective service, and homeless programs. So we need champions in every location and at every level. And I hope that all of you here and many of you listening in on the webinar are those champions. As Gwen mentioned at the beginning, we've been busy writing, and we've developed 2 policy briefs, one on key indicators for mental health services and one that describes our main study findings. And then we also have developed 3 fact sheets. One is on promising programs. These were programs across our 6 study counties that were identified by people and by administrators as being very beneficial to older adults. And they're kind of model programs. We have on the website not just the fact sheet, but a very detailed compendium that describes these programs fully and gives contact information. Because one of the things that the Mental Health Services Oversight and Accountability Commission asked us to do in our study was to identify things that other counties would be able to utilize, and they're hoping that these programs might be adopted and implemented in other locations. And then our last two fact sheets are very brief. I believe they're 3-pagers, right? 3-pagers on distilling these study results, and those are available both in English and Spanish. Kathryn and I worked really hard on this, but of course, as they say, it takes a village. So I wanted to recognize our project team members, and these are in alphabetical order. Adrian Bacong, Joanne Dameron Rodriguez, Homero Del Pino, Danielle Dupuy, Alina Palomaru, and Dalia Regos. We also were greatly assisted by our statewide project advisory committee. We worked hand in hand with them throughout the entire process. Everything we did, including our interview collection forms and all of our different reports, went through their review. And so they were a very, very important and super helpful group to the project. And I couldn't imagine doing this type of work without their support. So a great heartfelt thanks out to our statewide project advisory committee members. And then, of course, as mentioned, funding was provided by the California Mental Health Oversight and Accountability Commission. So at this time, I will turn it back over to Gwen to facilitate any questions, any comments that you guys would like to share.
We have a lot of online questions.
Hi, folks. This is Gwen again. We have a lot of online questions, but the way I like to do this is to take one from online, one from the room, one from online, and so on. I'm going to start with online since we have a lot and ask. There's a question right at the beginning of the seminar about how the MHSA was able to generate funding in the first place.
It was a public referendum because for a number of years after Governor Reagan changed mental health services to be more community-based. The problem was that the community-based services were never really funded. And so I believe a group of advocates over a number of years worked to get this on the ballot. Is that the correct answer? Okay. Yes.
There's enough impetus at the commission level to get these things going and work with the counties.
I think it's, I think it's a challenge because there are so many, as with so many social programs, benefits, et cetera, there's so many competing groups competing, and it really depends, and I think that's one of the major takeaways that we want to stress. It really depends that leadership and that voice for older adult mental health concerns is in that room, is on that commission, is speaking up. I do believe there are members of the commission that could assume that role. Some of them are more than others, but I think some groundswell needs to happen to rise up to the commission to increase advocacy and voice, in my opinion.
Yes, and it was interesting because I believe that our study was a mini intervention, because as we went into the counties and started setting up our interviews to meet with people for the key stakeholders interviews, it was amazing to us that when we got there, it was like just last week we met the area agency on aging person, or just last week we found out what was going on with older adults. So I think the fact that the state funded this study, and it was the first one since the passage of 2004, there was a lot of pressure from within that commission and their evaluation group to have a study such as this. But again, I agree with Kathryn that it's going to take a lot of, I think, political will to make things happen. We have received really great support from the California Mental Health Planning Council. And not necessarily because of this study, but perhaps it had some influence. Last year they did their data book, which is having the counties collect a lot of extra data around services, and they focused it on older adults. And they hadn't done that for, I think it was a number of years, maybe even
when
a
using the
decade.
term recovery, do you mean recovering from substance abuse disorder or having mental health issues become more manageable?
I think it's a really important question because I think recovery often in the common parlance might be associated in people's minds with substance use and addiction disorder specifically. I think maybe it has the history there, but under the MHSA and under more contemporary approaches to recovery from mental illness, it's a principle, it's a value that really encompasses the idea that people who have serious mental illness can be productive, engaged, healthy members of society as long as they have the supports to manage the mental illness. So in my understanding is recovery is really a broad principle that would be an umbrella above both substance use and mental health disorders, which are often linked. One may trigger the other.
Mm-hmm. So. But in the Mental Health Service Act, it means recovery and management from the seriously mentally illness, from the serious mental illness. Yeah,
you said it.
Okay.
Thank you. I was wondering if you could, excuse me, talk a little bit more about the workforce and training needs. I know you mentioned specifically geriatric training for those mental health providers, but I know there is also just generally a shortage of mental health providers in general. So if you have any thoughts on what the potential solutions are there.
So the reason that the workforce education and training is such a huge issue for older adult mental health care is because people do not get this in their training for the most part. And so the last data that's available that is quite old now is, for example, 5% of all social workers have one class about older adults and they graduate with their MSW. So they have requirements in school for training about children, and they do not have necessarily requirements about training for older adults. So it is an issue for good mental health providers and availability. So some of the ideas that we've had, and we're actually working with the Mental Health Planning Council now, as they're looking at workforce education and training. But some of the ideas that we have had have been around, perhaps there are these loan forgiveness and stipend programs to help people to try to address retention and recruitment needs, especially in some of the more hard to reach counties. And so if they prioritized students that were focusing on geriatrics, or at least were at a school that had a geriatric set of courses that they could take, you know, that would be a great idea and something that would be kind of a twofer, because they would get the person into their county, but they would also know something about older adults. But I think it's a very complex issue, and there is a state commission that is working on all of these issues.
Okay, from online. Can you speak to how the system serves people with co-occurring dementia and mental health issues?
Oh, great.
That's one of the big barriers because in terms of the funding policies, once somebody is diagnosed with dementia, they become sort of in the care of healthcare services. And so one of the issues with people who are aging with serious mental illness, if they develop dementia and they get diagnosed, they may lose that continuity of care that they've had for many years through the county mental health department. So it's an issue that was raised from almost day one, I think, from starting with our project advisory committee, that this is a very important issue that hasn't been successfully addressed, because you can't bifurcate somebody and say, oh, you know, you go over here for dementia care and you go over here for mental health care, and it makes no sense when continuity of care is so important. for people who have longstanding illnesses of any kind.
Yeah. And there are some great models. I know that San Diego County is implementing, it has plans to implement a program for dementia care, for cognitive impairment for their schizophrenic patients. And so there is recognition in some of the counties that they need to do something about this, but it's a huge issue.
I was wondering if you could, in your work, you discovered that perhaps whether some of the lack of services for older adults and training specific to older adults is in part due to a lack of awareness that older adults actually need and benefit from specialized care and training, and I don't know, maybe a belief that, you know, they're just adults and they don't need to be treated differently.
Yeah, we actually found exactly that. And the counties that have their older adults being served as part of their adult services and have nothing at all specifically designed for older adult services believe that to be true. And so I believe this is an educational opportunity. And again, leadership and advocacy. In the counties that have older adult systems of care or very, you know, perhaps co-located older adult and adult programs with specific ones for older adults, you know, they get it. And the people that tested out the innovation programs around integrative care have seen great benefit getting in front of some of the higher cost dollars by providing that kind of care, recognizing that older adults in general may have more comorbid conditions, more complex medical needs, and if they can take care of them, then it helps them self-care better for their mental illness and all the things that help them live a
Can we squeeze in one more
higher
from
quality
online?
of life.
What do small counties do who cannot hire a dedicated person for these services? And in addition, the data collection could be a hardship for some of these small counties. What do you recommend?
Yeah. Oh, is that me again? Okay. It is a huge issue for small counties, yet a number of small counties have figured out, you know, how to do this. And one of the things that we were recommending is that if there cannot be, just if it's totally not feasible to have a dedicated person within the mental health department, then we need to make sure that the mental health people are connected to the aging services people and vice versa. And so there would be a county-wide older adult advisory committee that could be formed, that could be that kind of watchdog type group. And also through committee meetings, make sure that older adults needs are being represented to the mental health and behavioral health units, and vice versa, that mental health units are being mental health needs are being recognized by the aging services administration and leadership. So I think there are, you know, perhaps workarounds with the small counties.
And then one example we saw that some of the area agencies on aging, what they do in small counties is that they have a regional mechanism where they work together as multiple small counties together. So it's a way of pooling the resources, and that could be a platform for this type of cross dissemination of information and sharing of resources.
Yeah, and on the data question, the problem is the Mental Health Service Act needs to answer to the citizens in California. They need to be able to tell them how many people are being served, of what age group, of what ethnicity and race. They need to be able to report these data. And so the only way they're going to do it is to be able to collect it. There is a new data collection system for the community supports and services that was also funded by the MHSA. It was run out of the University of California, San Diego. So there are tools available already for people to be able to collect more data, but all of those things are optional.
Well, really
They're not
interesting,
mandatory.
and I want to thank everyone in the room and online for participating. We will have the recorded video available in a day or less, we hope. Again, you can see all of the materials related to the study on our website, healthpolicy.ucla.edu. Thanks so much to our speakers, Kathryn and Janet.